taking this, we're 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 taking with a pinch of salt.
Dear ERA community, the subject of women and kidney disease is thankfully gaining more importance as time goes by. Every day, we become increasingly aware of the immense unmet needs in this scientific domain. It is only when we are faced with a young woman on dialysis or with advanced CKD who wants to discuss contraception or childbearing that we realize just how significant these unsatisfied needs are, how few clear guidelines exist, and how little we know whether any even exist. I am George Kosmadakis, a nephrologist from France, and your host for today's podcast, A Pinch of Salt. Our scientific community is becoming increasingly aware of the issue and is intensifying efforts to inform and educate on this very important topic. So the title of today's podcast is Pregnancy and Kidney Disease, Everyone's Business? To offer you some insights and initial guidance, we are honored to welcome Matt Hall, consultant nephrologist at Nottingham University Hospitals, UK, honorary assistant professor at the University of Nottingham School of Medicine, and chair of the East Midlands Maternal Medicine Network, Renal Division. In addition to this impressive professional background, Professor Hall is an accomplished guitarist, a top-class runner, and the father of two wonderful daughters. Matt, thank you very much for being with us today.
You're very welcome, George, and thank you for the lovely introduction.
It's really a pleasure. I will start straight away with the first question, which is, why is pregnancy an important subject for kidney teams to talk about?
Thanks, George. Well, I think all of us who help in the management of people with kidney disease look after women of childbearing potential, no matter whether you're in an outpatient or an inpatient setting, dialysis or transplant. And many patients will have strong opinions about their thoughts on pregnancy and look to us for advice. We have a phrase in English called the elephant in the room, which is where there's something, I don't know if you know of this, where there is an obvious thing that is evident to everybody and we don't talk about it. And that's true in two ways here, George. One is that we often don't talk about pregnancy at the right times with our patients. And also I wanted to draw attention to the fact that we have two, dare I say, middle-aged men talking about pregnancy and kidney disease today. But I think that's okay. And I think that's important to acknowledge that we all have a role in these discussions, no matter what our own personal situation is. So some patients will be clear that they do not want to start a family for whatever reason, because they've seen family members with similar issues, and we can help guide them on contraception choices. Some will be clear that they definitely do want to start a family, and we should be there to guide them through those risks that we can mitigate and how we can help them. And some will be uncertain and want more information. And we don't need to all be experts in pregnancy and kidney disease, but we should all have some information that we can direct patients to help them through that decision. So I think it's something that will affect us all at some point in our professional careers.
Well, you said we are middle-aged nephrologists, so we are old enough to have lived a lot of situations where we feel the responsibility of guiding young patients of childbearing age, and it is always a very complicated matter, and everything depends on what we know. And I am asking with stuff that I have already asked myself. So we hope to have an initial teaser of an answer. Of course, we will not finish in 20 minutes, but we might have an insight. Should women with kidney disease be told that it is okay to try to start a family?
I think this is a really important question, George, that I've come across, and maybe you have too, women maybe into their late 40s, 50s, who have chosen not to have a family, not through their own preference, but because somebody somewhere told them that they shouldn't. And actually, it's very uncommon that we should be advising anybody that they can never choose to have a pregnancy. There are risks, of course. There are some increased risks depending on where patients are. But if you look at the most recent information, we've moved on so far in the last 40, 50 years with likely outcomes of pregnancy for mums with kidney disease and for their infants. So the most recent studies over the last 10, 15 years would show that even with patients receiving dialysis or those with CKD stage 4 and 5, the infant survival is still very good, more than 90% most of the times, and it's usual for pregnancy to be successful in that respect. So we talk about risk and benefit of everything that we do in medicine, and we can be pretty good, and we can talk about this further, about the actual risks to women of going through those pregnancies, and we can give women that information for them to make up their decision. But what I don't think we can do as doctors and as nurses and as people dealing with helping the care of these patients is to quantify the benefit of a pregnancy, of what it means to that individual to consider a pregnancy. So I think our job is to inform and to listen and to support, rather than saying no to women who such a statement may affect the rest of their lives if we're not careful.
Of course, there is a change of paradigm, and there's a shift of the attention from medical-centered treatments to patient-centered treatments, and it's very comforting the fact that the percentages are even better, and we are giving the free choice to the young patients, considering the risks, and we share with them the risk, and that this is our job, to be informed on the risks and to tell them what is the risk and what are the chances.
Yeah, you're quite right. I think for some patients, the answer to the question, can I have a baby, might be not yet. There may be things that can be done to improve the chances. Say somebody who's heading for a kidney transplant in the near future, somebody who's had a recent relapse of lupus or vasculitis, etc. They may be better off pausing their plans for pregnancy. But even then, I don't think we should be saying no, never. We should be saying no, not yet, and leaving those doors open.
So you give an insight. You give the best advice possible in order to improve the chances. And therefore, it gets me to the next question. What are the top 5 tips on discussing pregnancy and kidney disease?
Thanks, George. And I must admit, you gave me forewarning of this question, so I have prepared 5 items that I can discuss. It's not off the top of my head, but I think the first important one I would say is don't put it off.
I wanted to exploit every second of this podcast. That's why I gave you the questions.
So one I'd say is don't put it off. Any chance you have to be discussing kidney care with a patient who's got the potential to be pregnant, ask them almost every time, and then you can discuss contraception or their plans, so that it's not left too late, or they're not unexpectedly pregnant when you could have done things that could have improved their chances. The second point would be, although we need to discuss some risks that pregnancy might cause their kidney disease, we should balance those risks of how we. My old colleague, Professor Brunskill, used to say, avoid catastrophizing, which is a word, avoid making everything a catastrophe. All these things could happen, but they probably won't. They probably won't for most people, and therefore it's important that they're mentioned but not dwelt upon. Thirdly, I'd say is that a lot of pregnancy management with kidney disease can be specialist and specialized and need the support of people who have experience in this area. So have a low threshold for seeking advice from colleagues. There's a lot of areas in this field which are, I would say, grey. The evidence is not strong, it's not definite, and there can be some opinions and experience-based medicine rather than evidence-based medicine that we should rely on our colleagues for. Number 4 is to plan ahead and think ahead. So if there's medication changes that are going to be needed to make a pregnancy safer, and the biggest example perhaps in renal medicine would be mycophenolate, an agent that's very, very useful in lupus and in transplant, but is very detrimental to pregnancy outcomes. If we want to consider a pregnancy in the near future, we need to proactively look for alternative agents that will be pregnancy safe, and the same goes with some other agents I'm sure you can think of. And then 5th, and I think this is really important, is to reassure patients who are asking about a pregnancy. They may have gone through a tricky time on dialysis and a complicated transplant or difficult immunology disease. Sometimes patients feel that it's a crazy idea that they should even contemplate pregnancy. But I think we should be reassuring patients that it's not a crazy idea. It is something we should think about and talk about, not rush into, but to support them in that decision making again. They're my 5 top tips.
Wonderful 5 tips. So, from what you say, we should be a source of hope and encouragement for them. I have a secondary question concerning the 4th tip. What about ACEs and ARBs?
Great. Yeah, so ACE inhibitors are probably the medication I get asked about the most. We know how, you don't need me to tell you, or I doubt anybody on this call who's listening, how useful ACE inhibitors are in protecting our patients from progressive kidney disease, and they are so useful. There was a study in the New England Journal in 2006 that suggested that if patients were exposed to ACE inhibitors in the first trimester, then they have an increase in some teratogenic effects. And that sent us all a bit into a muddle. Thankfully, there have been 2 very, very large population-based trials since then, including millions of patients. And although exposure of ACE inhibitors in the first trimester is associated with an increased risk of some abnormalities, some congenital abnormalities, that increased risk is no greater than you'd see with anybody on medication for high blood pressure in general. So there's no enhanced risk of being on that. And given that there's so much more benefit to, say, an ACE inhibitor over another agent for blood pressure control with kidney disease, our recommendation would be that if patients want to consider a pregnancy, they should continue their ACE inhibitor until the moment they have a positive pregnancy test and then immediately discontinue. And the secondary to that is that if people have a potential for becoming pregnant on an ACE inhibitor, then they should take a pregnancy test every month, just so they don't accidentally find that they're 4 or 5 months pregnant. It's uncommon, but it could happen, and that's where the danger occurs. So that's the evidence-based guidelines that we would follow now, is to continue until pregnant.
Continue until a positive pregnancy test that should be performed every month.
Yes.
Perfect. Okay. So, our specialty is evolving, and every year I listen a new adjective before the word nephrology. And now we have obstetric nephrology. And I love it because I was always jealous of cardiologists who had 25 different type of subspecialties. So I think, it's very classy to have subspecialties in nephrology as well.
Yeah.
What is new in obstetric nephrology, Matt?
So I think part of what you mentioned there is very important, is that we do have more of a subspecialty in obstetric nephrology. And certainly in England and in the UK, but I know in other countries as well, what we've really tried to concentrate on is ensuring that everybody, all patients and all clinicians, have access to these pockets of expertise, say in obstetric nephrology or in metabolic medicine or in genetic nephrology. We can't all be experts in everything. So I think one thing that's new and is really helping patient outcomes in the UK is that every patient has access to a maternal medicine network where you can tap in to specialist expertise in all other specialties for maternal medicine issues. And it sounds fairly simplistic as a concept, but actually the benefits to remove that isolation that some clinicians can feel dealing with complex patients, enabling patients to have their care closer to their home as well during this really special time of a pregnancy, that's made a huge difference. And through these networks as well, another benefit is the increase in data that we have that we can use to advise patients. So all of our information, most of our research is based on observational data. That's going to maintain the case. It's very difficult to do randomized controlled trials in pregnancy. So we need more and more data. And as we have more and more data, then we can start to really individualize those projections and those prognoses for pregnancy in patients and really help as I say, it goes back to the decision making for the mums to be about pursuing a pregnancy. If we can give them really high quality data, and I'm delighted that my colleagues based in King's College London, but also around the country, Kate Bramham and others, are really trying to hone in on this predictive calculator where we can put in some fairly simple parameters that give you the likelihood of various outcomes in much more individualized data. And that's going to be really powerful and really useful in these decisions and discussions that we have with patients and moving forward. I think furthermore to that is that as we get that data, we can be more and more confident, I think, in advising women about the likely outcomes and the likely successes of pregnancy and kidney disease. So I think we can say nowadays, if a woman goes into a pregnancy with, you know, only mildly impaired kidney function, say a GFR more than 45, then it's very unlikely that that pregnancy will adversely affect their kidney trajectory, their kidney pathway in any way. They're likely to come out of that pregnancy as they went into. If you have more advanced kidney disease, then we've got data now to suggest that although pregnancy may affect that kidney trajectory, it tends to do it in a stepwise drop rather than accelerating the trajectory of kidney decline. So you lose between 1 and maybe 4 years of kidney health through a pregnancy with more advanced kidney disease. And you can simply project that to the patient and say, you know, this is what we think may happen. And dare I say, is that worth it? That question, the patient is empowered to answer that for them. So this is where data really becomes, you know, pragmatic and useful for the people that are dealing with it. We have more useful information about children born to mothers with kidney disease. Again, it's been an unmet need of data as to whether developing in the uterus of women with kidney impairment, is that going to have a detrimental effect long term? And I think reassuringly and progressively so, there isn't a strong signal of harm or concern amongst the children being born. There is a risk of prematurity, yes, an increased risk of that, and that can affect, but above and beyond that, then the outcomes are really good. So I think that combination of team working and networking across regions to enable access to expertise, increase data so we can make these projections and predictions more accurate, and then transfer that into more confident statements for parents to make those decisions. I think that's where we're heading pretty quickly.
Perfect. So we see that expertise is accumulating. We have more and more information on the subject. Do you think we'll have sometime soon some specific guidelines on a national or international level?
Yes, and I know there are a number of nations have some national guidelines that they have published. I know that's true in the Netherlands and in Italy and in the UK. We should probably come together because they're very similar and share expertise on that, and moreover renew those regularly. So as part of the team contributing to the UK guidelines, but I think in the next iteration of those guidelines, what I'd hope to see is the quality of evidence in the guidelines starting to go up the rank from opinion and observational studies into a bit more solid data. So that's a real hope for the future. But through the guidelines that we have had before and contributed to and used, it is enabling that sharing of information and comparison of outcomes. If we're doing all the, dare I say, simple things well, like blood pressure control and like timing of birth and use of aspirin to reduce the chance of preeclampsia, etc., then those simple things done well are really helping to move us forward. What's next? Well, I don't really know what's next, but I'd hope that we'd have more information about how to offer dialysis more effectively in pregnancy. I think we're still in the dark on that a little bit as to exactly what the best way to dialyze for the benefit of the patient and the mum is. I think, again, with the outcomes being so much better than they were 30 years ago, more and more of us are looking after women having dialysis during pregnancy. And the same with transplant and the timing of transplant and how long to wait after a transplant before recommending pregnancy and what we can do with the medicines. It's just more nuanced and niche advice on that. would really enhance those patient outcomes even further than we've already done so, I think.
Wonderful. Things are accumulating very fast. I remember the first chapter I read 20 years ago on pregnancy in CKD was 4 pages probably, with not much of information. Things are getting even further, and that's wonderful. And we are very much sensible with all these predictive tests. And I have a double question: whether we have any predictive tests concerning the preeclampsia and concerning the evaluation of renal reserve and the predicted pregnancy-associated loss of kidney function?
Yeah, I have a big problem with preeclampsia, and this is somebody who's tried to study and work on preeclampsia for 20 years. In that, when you're talking about preeclampsia in people with kidney disease, i.e., they've already had high blood pressure and they already have proteinuria. Uh, I don't know what preeclampsia is, and I don't think anybody else does in as much detail as we'd like to. And we talk about superimposed preeclampsia. So you may have heard of, there are some predictive tests for preeclampsia. There's SFLT1, which is a placental derived growth factor, and placental growth factor, which are in combination. You can measure one or the other or both, and that's been evidence based in patients without kidney disease to be strongly predictive of whether or not the pregnancy should be ended within the next 2 weeks because of preeclampsia. And they're markers of the placental stress that occurs as a precursor to preeclampsia, and they are very useful. But because, I mean, if you take an example of somebody with a kidney transplant, at say 30 weeks, and their creatinine starts to increase and their blood pressure starts to increase and the proteinuria starts to increase, the differential diagnosis there is so much broader than for the general population. Is this tacrolimus toxicity? Is this kidney rejection? Is this preeclampsia? Is this just the physiological changes of a kidney that's struggling with the stress? And if we had a test in that situation, it would make a huge difference. But when we've looked at SFLT1 and placental growth factor in patients with chronic kidney disease, it's not quite as sensitive and not quite as specific. So it can still be used to help predict preeclampsia, but it's not as good as in the general population. So still use it, but it needs more of a caution around its interpretation. So we're still stuck really with other markers of placental function to try and predict preeclampsia, and they can be those bioparameters such as blood pressure and proteinuria, although that's fairly late. It can be on uterine artery Doppler flow and seeing how the flow through those is being compromised or not. It can be using fetal growth charts and seeing how well the baby is growing. But we've still got lots of these soft indicators that we need to pop together. And the placental growth factors are really a cherry on the top of the cake rather than the cake itself in this situation. So I remain confused and baffled in how to effectively identify and treat preeclampsia in patients with chronic kidney disease. But what I do is I've advised in other places is to have a consensus opinion on that. We need to be making decisions with our obstetric colleagues and looking at the picture as a whole to work out which arm of the pathology is predominant in these situations. I think we can be sorry. I think we can be accused of as a kidney community over 20, 30 years of panicking too early. Maybe not panicking, but calling for the end of a pregnancy when the first sign of difficulty occurs, when the first blip in creatinine or the first touch of hypertension. And 90 to 95% of cases of preterm birth in patients with kidney disease are due to an elective section or induction of labor. It's not because of spontaneous labor or spontaneous rupture of membranes of the mother. So, I think if we had more information about exactly what was going to happen next, we'll be able to prolong pregnancies a little longer, and that's what we hope for. But I haven't got a test yet. I'll keep crossing my fingers.
Yeah, it's a work in progress. We chose this subject because some of us have read in the first textbooks of medicine these horrible percentages of mortality for both fetus and women, and it's a wonderful thing that you are so comforting and so optimistic in a medical way, not
Yeah.
romantic, but data is accumulating. We have more and more information. We have more specific pieces of advice to give to our patients.
Yeah.
I have yeah. Do you want to add something? Yeah.
No, only to say that I think that optimism is there because we haven't had a huge what we call paradigm shift. There hasn't been a new wonder drug or a new wonder treatment. It's been a combination of enhanced intensive care management, obstetric management, and the use of simple things like aspirin for almost anybody with kidney disease to reduce preeclampsia, thinking about thromboembolic risk, early treatment of hypertension and urinary tract infections. And I think it's not a super specialist management that's needed in these cases. It's just doing the simple things well and being confident that you are doing the simple things well, and the outcome is what it'll be.
Of course, and by discussing with all the specialists in various subjects, their medicine is not a revolution; it's a step-by-step evolution of our practice every day, consistently.
Yeah.
My last medical question is concerning SGLT2 and pregnancy.
Thank you.
Do you have any data, Matt, on this?
That's a brilliant question, and it was on my list to bring up if we hadn't got there. So thank you,
Yeah.
George. Absolutely, yeah. So again, like ACE inhibitors, SGLT2 inhibitors, we should put them in the drinking water. Do you think? They're so useful for everything. I joke, of course, but you're right. They are so revolutionary in terms of protecting kidney function for people with proteinuric kidney disease, and that includes women of childbearing potential. We've got this huge body of data with ACE inhibitors that give us confidence to know what we're going to do with them. With SGLT2 inhibitors, we don't have that body of safety data. So we are reliant at the moment still on observational data, animal studies, experiential learning of what's going on. And the evidence so far does not point to a harm. So those women who have been exposed to SGLT2 inhibitors in the first trimester, there isn't a safety signal in terms of fetal teratogenicity or other problems. So our advice at the moment is the same, really. If people need an SGLT2 inhibitor, they should continue it and be counseled. If they are not using reliable contraception, then they should have early pregnancy tests done. But it's a bit more of a nuanced discussion about whether they should stop beforehand or not. I think we aren't in a position to confidently say they continue it at the moment. And therefore, it gets back to this two-way conversation on the risk and the benefit. Personally, if somebody requires them because they're heavily proteinuric and they've got risk, then I would be counseling them to say, I suggest you carry on. But really that is, but there are risks associated, risks of the unknown rather than risks of proven harm.
Right. So it's another work in progress and things are unknown. It's a very good subject because we can call you back 2 years from now to tell us the news.
Yes, indeed.
So now, we pass to the typical personal questions. And could you share with us the book, 2 songs and luxury item you would take with you in a desert island?
This was the most difficult part of preparation, George.
Of course, I know.
So the book, I thought if I'm on my own on a desert island, I don't want a fiction book because I know how it ends if I wanted to read it again. So what I've done is I've picked a book that's been on my bookshelf for a number of years and I've never quite got to the end of it because it makes me think too much. And it's a book called The Human Touch by Michael Frayn. And this is an exploration of sort of philosophy and psychology and putting yourself in the universe and how insignificant and significant we are. And I get to about chapter 4 on it, and then I can't cope anymore because it's too mind-blowing. But I think if I'm stuck on a desert island on my own, that'll keep me excited for the rest of until the plane comes to pick me up. And I might get to the last chapter one day. My 2 songs, George, you've had the misfortune of hearing me play guitar before, and you'll know that
I had the pleasure of hearing you.
That underneath my mild-mannered professional exterior, I like very loud music played very fast. So my 2 songs really, I've got one song to get me up in the morning and one song to get me home. So my get-up song is by the heavy metal band Slipknot, and it's Sick, spelled S-I-C. And if you listen to the introduction of Sick by Slipknot, you'll be awake. It'll definitely wake you up. And then to get me to sleep is a much more relaxed though the band The Eagles, who a bit of country rock and peaceful, easy feeling by The Eagles, I think is a lovely tune, lovely melody, and a great way to finish a day as the sun goes down over my desert island. Um, and my luxury item will obviously be my guitar, because I couldn't cope without that. And in fact, if I could take 3 guitars, that would be even better.
Wonderful. Wonderful. Well, we should definitely do this playlist because the choices of our guests are really interesting and wonderful. Probably we should do a list of the books. Matt, it was a real pleasure to discuss with you today on this important subject. Dear colleagues, as you see, obstetric nephrology is evolving, creating new answers and even more questions on these issues concerning women's renal health. We hope today you had some insights to search for more, to be prepared for your young female patients who have the right for the full life options of their choice. Catch up on all the other previous excellent ERA podcasts available in all these wonderful available platforms. Please share the news with your colleagues. Thank you for your time and all the best.